electrocardiogram, or ECG, or the Dutch or German version of the word EKG, is a tool used to visualize the electricity that flows through the heart. An ECG tracing specifically shows how the depolarization wave moves during each heartbeat, which is a wave of positive charge. And the way it looks depends on the set of electrodes you're using. This particular set of electrodes is called lead 2, for example, with one electrode on the right arm and the other on the left leg. So essentially, when the wave's moving toward the left leg electrode, you get a positive deflection, like this big positive deflection corresponding to the wave moving down into the left and right ventricles. To read an ECG, there are a few key elements to keep in mind. The term ischemia means that blood flow to a tissue has decreased, which results in hypoxia, or insufficient oxygen to that tissue. Whereas infarction goes one step further and means that blood flow has been completely cut off, and this results in necrosis, or cellular death. That typically happens if blood flow has been cut off for about 20 minutes. In the heart, ischemia and infarction can be transmural, affecting the entire thickness of the myocardium. But it can also be subendocardial, affecting just the innermost part of the myocardium, the part just beneath the endocardium. Out of all four chambers of the heart, the ECG is most sensitive to transmural or subendocardial ischemia or infarction in the left ventricle, because that's the chamber with the thickest walls and therefore has the most cardiac tissue. Alright, so let's start with subendocardial ischemia, which might happen when there's an incomplete blockage, let's say about 70%, in the coronary artery. In that situation, at rest, there's usually enough blood flowing to meet the demand of the myocardium. But during exercise, there's not enough to meet the myocardium's increased demand. In that situation, the subendocardial tissue gets ischemic, because it's the last bit of tissue to get blood from the tiny branches of the coronary arteries as they make their way through the ventricular wall from outside to inside. This condition is called stable angina, because there's ischemia which causes chest pain with exercise, and then it disappears with rest.
And there's also unstable angina, which can happen with incomplete blockage of a coronary artery, but in this case, chest pain appears at rest.
When there's subendocardial ischemia in a region, it causes ST depressions in the corresponding lead on the ECG. An ST depression is when the J point, which is where the QRS complex meets the ST segment, goes down by at least 0.5 millimeters, or 1/2 of a small box. The ST depression can be upward sloping, downward sloping, or horizontal. In subendocardial ischemia, ST depressions are usually widespread, often affecting leads 1, 2, and V4 through V6. With such widespread involvement, it's tough to determine which coronary artery caused the ST depression. As a little side note, if the ST segment is depressed and curved, it might actually be due to digitalis effect, which is when the patient takes the medication digoxin, rather than being due to subendocardial ischemia.
On the other hand, subendocardial infarction happens if the coronary artery remains blocked for around 20 minutes. And the subendocardial cells begin to die, resulting in necrosis. And with necrosis, the subendocardial cells leak cardiac enzymes, like troponins and CKMB, into the blood. With a subendocardial infarction, there is no ST elevation on the ECG, so this is called a non-ST elevation myocardial infarction, or an NSTEMI for short. Instead, the ECG can show ST depression and T-wave inversion. On ECG, both unstable angina and NSTEMIs might show ST depression as well as T-wave inversions. The difference is that with NSTEMIs, cardiac enzyme levels in the blood are elevated, whereas with unstable angina, the damage resolves in a short time window, so there's no cardiomyocyte death, and therefore no elevated cardiac enzymes. With an NSTEMI, the ST depression looks similar to the one in subendocardial ischemia,
and the T-wave inversions are usually symmetric and at least 1 millimeter deep, or one little box, and are most noticeable in the chest leads, but can also appear in the limb leads. These also have to happen in at least 2 contiguous leads, meaning adjacent leads. For example, lead V2 and V3 are contiguous, but leads V3 and V5 are not contiguous.
There can also be a dominant R wave, meaning that the R wave has a higher amplitude than the S wave.
Now, it actually turns out that a little bit of T wave inversion can be normal, especially in leads 3, AVR, and V1. But any sign of T wave inversion in leads V2 through V6 is considered abnormal. Alright, so next there's transmural ischemia. And this can happen when a coronary artery is narrowed from an atherosclerotic plaque buildup over time. Now, there are two parts to this plaque: a hard fibrous cap and a soft cheese-like interior. As the blood flows past the plaque, the fibrous cap can sometimes rip, and that cheesy interior is exposed and considered thrombogenic, meaning that blood clots form on it really quickly, and that can quickly plug up blood flow.
Transmural ischemia can happen secondary to vasospastic angina, also called Prinzmetal angina, which is when a coronary blood vessel spasms and narrows, cutting off blood flow to that cardiac region. Vasospastic angina happens independent of traditional risk factors, like atherosclerosis, and can be triggered by tobacco, alcohol, or cocaine use.
Finally, we have transmural infarction, which happens when a coronary artery becomes completely blocked for greater than about 20 minutes, and this causes transmural necrosis. Within minutes, a transmural infarction leads to ECG changes. The most common would be a T-wave inversion, but there might also be hyperacute T waves, which are large, asymmetric T waves that appear in at least two contiguous leads. The classic sign of transmural infarction is ST elevation, and when that happens, it's called an ST elevation myocardial infarction, or STEMI. On ECG, the ST elevation at the J point must be over 1 millimeter in any two contiguous leads except V2 or V3, where it has to be over 2 millimeters.
On an ECG, both a STEMI and vasospastic angina can cause ST elevations, but with vasospastic angina, the elevation is transient. Another key difference is that with a STEMI, the ischemia is so severe that damaged heart cells die, resulting in myocardial necrosis, and leak out certain enzymes like troponin and CKMB.
ST elevation, though, can also be caused by other conditions, like left ventricular hypertrophy and pericarditis. As an example, a 20-year-old physically fit person with a viral illness that gradually develops chest pain and is found to have ST elevation on ECG is actually more likely to have pericarditis than an ST elevation myocardial infarction.
Besides ST elevation and T-wave inversions, a transmural infarction can also cause pathologic Q waves to appear on the ECG.
Normally, depolarization in the ventricle spreads from the endocardium to the epicardium, and most of that ends up pointing toward the positive electrode, which means a positive deflection. With infarcted tissue, though, it doesn't conduct electricity, which means that the electrode essentially sees through the infarcted tissue, sort of like as if it was just a hole. And it sees through the hole to the other ventricular wall. And since those are mostly moving away from the positive electrode, you end up with this big, negative pathologic Q wave. So pathologic Q waves are those that are longer than 0.04 seconds, or one small box, and over 2 millimeters, or 2 small boxes deep. Now, the location of the transmural infarction can be identified based on the lead that has pathologic Q waves. Septal wall infarctions show changes in leads V1 and V2, whereas anterior wall infarctions show changes in leads V3 and V4. Anterolateral wall infarctions show up in leads V3 through V6, as well as 1 in AVL. Small subendocardial infarctions don't actually cause pathologic Q waves, because some of the affected wall still conducts electricity. Also, the AVR lead is oriented in a way that normally produces Q waves, so it's actually not a reliable lead to look for pathologic Q waves. Finally, pathologic Q waves can also result from things other than transmural infarction, like a left bundle branch block and Wolff-Parkinson-White syndrome. After a transmural myocardial infarction, the ECG gradually starts to look more normal. During the first 2 days, there might be T-wave inversion, ST segment elevation, and pathologic Q waves. But around day 3, the ST segment's often back at baseline. After a few weeks or months, the T-wave inversion might start to improve as well. But pathologic Q waves can linger for a lot longer. And this is why it's always important to compare ECGs to previous ones to look for new changes. Alright, as a quick recap.
Subendocardial ischemia can reflect stable or unstable angina. Subendocardial infarction causes an NSTEMI. Stable angina, unstable angina, and NSTEMIs are associated with ST depressions and T-wave inversions on ECG. But the difference is that with NSTEMIs, there are elevated cardiac enzymes like CKMB and troponins in the blood. Transmural ischemia can reflect vasospastic angina, whereas transmural infarction leads to a STEMI, and this causes ST elevation on an ECG. The key difference is that with vasospastic angina, the ST elevation is transient, and with a STEMI, there are elevated cardiac enzymes in the blood. Additionally, with a STEMI, the ECG can show T-wave inversions and hyperacute T waves, as well as pathologic Q waves.
Hypertrophy means that the heart's muscular walls increased in thickness, while dilation refers to an increase in the volume of a chamber. The term enlargement is generally used when both hypertrophy and dilation happen together, and this is what typically happens in the atria. In contrast, the ventricles often undergo hypertrophy without dilation. An ECG can show evidence of hypertrophy and enlargement in all the heart's 4 chambers. So let's go through them one by one. Normally, atrial depolarization produces a pretty normal-looking, symmetric P wave. In right atrial enlargement, all that extra right atrial muscle tissue results in a large P wave in leads V1 and V2, often over 1.5 millimeters, as well as in the inferior leads 2, 3, and AVF, often over 2.5 millimeters. One reason why right atrial enlargement develops is that there can be a stenotic or narrowed tricuspid valve, and that makes it difficult for the right atrium to eject blood into the right ventricle, and in response the right atrium enlarges. In left atrial enlargement, the left atrium has extra muscle tissue, and that results in a P wave with 2 peaks in lead 2, with the entire thing stretching out over 110 milliseconds, with a gap of over 40 milliseconds separating the 2 peaks.
With left atrial enlargement, the P wave in lead V1 is biphasic, meaning that it looks like a hill with a valley alongside it. However, that can also be seen in healthy individuals. The key difference between a normal and pathological biphasic P wave in V1 is that with left atrial enlargement, the negative portion is usually more than 1 millimeter deep and lasts for more than 40 milliseconds.
Left atrial enlargement also develops from a stenotic valve, but this time it's the mitral valve on the left side, which causes the left atrium to get bigger. Normally, the QRS complex is mostly negative in lead V1, because the large left ventricle, which carries the greatest amount of muscle tissue, is oriented down and away from this electrode. In right ventricular hypertrophy, the thicker right ventricle helps to counterbalance the left ventricle, and so it makes lead V1 more positive. More specifically, it makes the R wave bigger, which is the upward deflection of the QRS complex. In fact, a dominant R wave in V1 is a classic sign of right ventricular hypertrophy, and it's defined as one that's over 7 millimeters tall, or 7 little boxes, and is larger than the S wave, making the R to S ratio greater than 1. In V5 and V6, another classic sign of right ventricular hypertrophy is a dominant S wave, meaning that it's over 7 millimeters deep, again 7 little boxes, and bigger than the R wave, making the R to S ratio less than 1. Typically, there's also right axis deviation in right ventricular hypertrophy, resulting in an axis of plus 110 degrees or more. In right ventricular hypertrophy, the QRS complex is less than 120 milliseconds, meaning that it's not longer than normal. This is important because it means that the changes can't be the result of something like a right bundle branch block, which would cause a longer than normal QRS complex. Right ventricular hypertrophy can develop for a number of reasons, a common one being pulmonary hypertension, which makes sense because the right ventricle has to build up muscle to push blood against higher pressure into the lungs. In left ventricular hypertrophy, the pattern is almost the opposite of what happens in right ventricular hypertrophy. Lead V1 has even more positive charge traveling away from it than usual, making the S wave really deep. Meanwhile, lead V5 and V6 are located on the side of the left ventricle, and therefore have an enormous R wave. The most commonly used voltage criteria to identify left ventricular hypertrophy is that adding up the S wave in V1 and the tallest R wave in V5 or V6 has to be over 35 millimeters, or 35 little boxes. Additional criteria include things like having an R wave that goes on for longer than usual, typically over 50 milliseconds, as well as ST segment elevation in V1, and ST segment depression and T wave inversion in V5 and V6. And these are all signs that the left ventricle is straining during muscle contraction. Left ventricular hypertrophy commonly develops due to systemic hypertension, or elevated systemic blood pressure, since the left ventricle needs more muscle so that it can eject blood against higher pressures. Alright, as a quick recap.
Right atrial enlargement shows a big P wave in lead 2 and V1, whereas left atrial enlargement has a biphasic P wave in lead V1 with a negative component greater than 1 millimeter deep and lasting more than 40 milliseconds, as well as a double humped P wave in lead 2.
Right ventricular hypertrophy shows a big R wave in V1 and a big S wave in V5 and V6, whereas left ventricular hypertrophy shows the opposite, a huge S wave in V1 and a huge R wave in V5 and V6, adding up to over 35 millimeters,